Welcome to this lecture about diagnosis of early intrauterine pregnancy. Structure development. Structure generally developed in the following predictable sequence. 1. Gestational sac. 2. Double cell reaction. 3. Yolk sac. Yolk sac with intrauterine gestational sac confirm early intrauterine pregnancy. Embryo and embryonic heartbeat. Pelvic ultrasonography and testing of the beta subunit human chorionic gonadotropin serum level are key of diagnosis of early pregnancy and guide management of its associated complication. Ultrasound imaging in early pregnancy should be primarily endovaginal with transabdominal imaging used for adnexal masses high in the pelvis and documentation of the amount of free fluid. Early pregnancy ultrasound examination. First trimester dating should be determined by crown rumblance, not from mean gestational sac diameter, as the latter is less accurate. Estimated date of delivery and gestational age from known in vitro fertilization days should be not changed. Most early pregnancies can less than 7 weeks will require transabdominal and transvaginal imaging. Transabdominal imaging alone may be sufficient if excellent visualization of a live intrauterine embryo is achieved and the woman is asymptomatic. Transvaginal imaging should always be offered when the indication includes abnormal symptoms such as bleeding or pain. Normal development of early intrauterine pregnancy between 4 and 8 weeks of gestational age. A gestational sac can first be visualized by endovaginal ultrasound at 4.5 to 5 weeks of gestational age as 2 to 3 mm rounded intrauterine fluid collection. The mean sac diameter growth rate is 1.13 mm per day, but this is often variable. Before visualization of the yolk sac or embryo to confirm the fluid collection as a true gestational sac, two important signs may be used. First one, the intradecidual sign, and this is defined as an eccentrically located gestational sac within the echogenic decidua, with a relatively undisturbed collapsed uterine cavity visualized at a thin echogenic line, which is highly suggestive for intrauterine pregnancy. The second one is the double sac sign, consisting of two concentric echogenic rings surrounding the fluid collection and separated by a thin crescent of endometrial fluid. This is a sign of definitive intrauterine pregnancy. The outer echogenic ring represents the decidua parietale and the inner ring represents the decidua capsularis and the chorion. Diagnosis of early intrauterine pregnancy, takeaway message. In a patient with positive human chorionic gonadotropin and no adnexal masses suggestive of ectopic pregnancy, any fluid collection with rounded edges in the central echogenic portion of the uterus must be interpreted as highly likely gestational sac. Treatments that can damage an intrauterine embryo, including methotrexate therapy, DNT, should be avoided unless a normal intrauterine pregnancy is definitely excluded. Here is an endovaginal ultrasound demonstrate an intradecidual sign in a pregnant woman with pelvic pain. And 2 mm rounded gestational sac is embedded within the decidua, adjacent to a collapsed endometrial cavity. Endovaginal ultrasound images show the double sac sign in a pregnant woman with pelvic cramp, a 4 mm gestational sac surrounded by two echogenic rings. The inner ring represents the decidua capsularis around the chorion, while outer ring, this is the decidua parietalis. The yolk sac. The yolk sac is the earliest intergestational sac structure to be visualized at ultrasound that can be absolutely confirm an intrauterine pregnancy. It's the primary maternal fetal transport system before the establishment of a fully developed placental circulation and can be visualized at approximately 5.5 weeks of gestational age at a rounded 3 to 5 mm structure, usually eccentrically located within the gestational sac. The yolk sac may be sometimes appear as two barren lines, representing the leading edge and the posterior wall rather than a discrete circle. Here is an endovaginal ultrasound image showing a normal yolk sac at varying stages of early pregnancy. The yolk sac here is an eccentric rounded echogenic ring, while the yolk sac here is a two-barrel line representing the leading edge and the posterior wall. The embryo. The embryo is first visualized at approximately 6 weeks of gestational age as 1 or 2 mm structure at the periphery of the yolk sac, The length of the embryo measured from the head, colon, to the buttocks rump. Here's the term crown rump length, which is the most accurate measurement of gestational age through the first 12 weeks of pregnancy. The embryo should be visualized when the mean stat diameter at least 25 mm. Here is an endovaginal ultrasound in a pregnant woman demonstrating the crown rump length. The crown rump length 3 mm and adjacent to normal yolk sac. The embryo resides within the amniotic cavity, and the yolk sac resides within the chorionic cavity. In normal gestation, the chorionic cavity, amniotic cavity, and crown rump lengths grow proportionally until the onset of fetal urine production at 10 weeks. The fetal urine disproportionately enlarges the amniotic cavity, which then grows faster than the chorionic cavity, with eventual fusion of the amnion and chorion at 14 to 16 weeks. Here is an endovaginal ultrasound in a pregnant patient showing normal amnion. Here is the amnion and the crown rump length, and also there is a rhombocephalon, and also there is a lip budding. Here is the yolk sac, the amnion, the amniotic cavity, the chorionic cavity also. Cardiac pulsation cardiac pulsation in the tubular endocardial heart tubes begins approximately at 6 weeks of gestation. Thus, it's possible to observe cardiac activity in embryos as small as 1 to 2 mm. However, absence of cardiac activity in embryos smaller than 4 mm may also be normal. The Society of Radiologists in Ultrasound established a measurement of 7 mm and larger as the crown rump length at which cardiac activity should be present. Thus, a definitive diagnosis of failed pregnancy may be assigned only if the embryo is at least 7 mm and lacks cardiac activity. Endovaginal M-mode ultrasound in a pregnant patient demonstrates normal cardiac activity of 122 beats per minute. The crown rump length is 3 mm and the gestation sac is of 6 weeks and 3 days. Here is endovaginal ultrasound image of pregnant patient with vaginal bleeding. Initial image shows normal yolk sac and crown rump length of 2 mm. Projecting into gestational age of 5 weeks and 6 days, and no cardiac activity detected. Follow-up images obtained 12 days later shows appropriate interval growth of the embryo, and the crown rump length become 11 mm, projecting into gestational sac of 7 weeks and 3 days, and the M-mode images shows normal cardiac activity of 150 beats per minute. Abnormal early intrauterine pregnancy. The timing of visualization of early pregnancy landmarks. Gestational sac at approximately 5 weeks of gestation. Yolk sac at 5.5 weeks. And the embryo at 6 weeks, with variation of 0.5 weeks, is accurate and consistent. Thus, any deviation from this expected time course may be either indicative or definitive for failed pregnancy. Discriminatory value for absence of cardiac activity at certain crown rump length, absence of the embryo at certain mean sac diameter, and time-based non-visualization of a live embryo were established in 1980 when the endovaginal ultrasound was first deployed. Endovaginal ultrasound images shows findings suspicious but not diagnostic for pregnancy failure. This is a finding of non-viable intrauterine pregnancy. At follow-up ultrasound, initial imaging are suspicious for pregnancy failure but not diagnostic. There is an irregular gestational sac with mean sac diameter 17 mm and enlarged empty amnion, and no embryo or yolk sac. Follow-up images obtained 10 days later shows non-viable intrauterine pregnancy, and there is a lack of appropriate interval growth of the gestational sac and no also embryo. Note there is a hydropic changes here in the chorionic line. Intrauterine pregnancy failure have 4 definite diagnostic criteria for intrauterine pregnancy failure. 2 are size-based and 2 are time-based. Definitive diagnostic criteria for intra-pregnancy failure. 1. Crown rump length is 7 mm or greater without cardiac activity, with positive predictive value of 100%. Definitive diagnostic criteria of intrauterine pregnancy failure. Second one is mean sac diameter about 25 mm or greater without visible embryo. It's also 100% post-predictive value for failure. Here's an endovaginal ultrasound demonstrate non-viable intrauterine pregnancy. There is an empty gestational sac with mean sac diameter 29 mm, and here is also fine linear echogenic depressed noted in the sac, but there is no yolk sac or embryo. The estimated gestational age is 8 weeks and 1 day. These findings are keeping with non-viable intrauterine pregnancy because the mean sac diameter measure at least 25 mm. Definitive diagnostic criteria for intrauterine pregnancy failure, third and fourth one. The third one, absence of embryo with heartbeat equal 14 days or greater after a scan that shows gestational sac without a yolk sac. Number 4, absence of embryo with heartbeat 11 days or greater after a scan that shows a gestational sac with a yolk sac. Here is also an 8 suspicious criteria for intrauterine pregnancy failure. Intrauterine pregnancy of uncertain viability. Crown rumblance less than 7 mm with no heart motion, mean sac diameter of 16 to 24 and no embryo, absence of embryo with heart motion 7 to 13 days after scan showed a gestational sac without a yolk sac, absence of embryo with heart motion 7 to 10 days after scan showed a gestational sac with a yolk sac, empty amnion sign, enlarged yolk sac 7 mm or greater, small gestational sac in relation to the size of the embryo, and absence of the embryo 6 weeks or greater after last menstrual period. Number 1. Crown rumblance less than 7 mm with heart motion. Here is cardiac flicker, usually seen early with a little embryo. Note that any embryo without heart motion is suspicious. Mean sac diameter of 16 to 24 mm and no embryo. Absence of embryo with heart motion 7 to 13 days after scan shows gestational sac without yolk sac. Absence of embryo with heart motion 7 to 10 days after a scan showing gestational sac with yolk sac. Number 5. Empty amnion sign. Sonographic visualization of the amnion adjacent to the yolk sac. Here is the yolk sac and here is the embryo, the amnion. Where is the embryo? That's not the order that's supposed to appear. The embryo has to appear first. Enlarged yolk sac more than 7 mm, as a normal yolk sac is less than 6 mm. Number 7. Small gestational sac in relation to the size of the embryo. If the mean sac diameter minus crown rumblance is equal to or less than 5 mm, this is abnormal. First trimester oligohydramnios here also. Number 8. Absence of embryo of about 6 weeks or greater after normal last menstrual period, and this would only be considered as very regular cycle and pregnant with associated reproductive technique. Take-home message. Order of appearance of early pregnancy is essential for diagnosis of intrauterine failure. 4 definitive diagnostic criteria for intrauterine pregnancy failure. 2 are size-based and 2 are time-based. 8 suspicious diagnostic criteria for intrauterine pregnancy failure. Absent cardiac activity by certain crown rumblance, absent embryo by certain mean sac diameter, absent embryo by certain point of time. 3 criteria. Abnormal morphology of gestational sac, amnion and yolk sac. 3 criteria. When there are findings suspicious for pregnancy failure, follow-up ultrasound at 7 to 10 days is considered. Thanks.